So I'm very pleased to open the session with the first presentation from Professor Kaarin Anstey, who is an ARC, Australian Research Council Laureate Fellow and Scientia Professor at University of New South Wales and a Senior Principal Research Scientist at Neuro. She is a Director of the University of New South Wales Aging Futures Institute, leads a National Health and Medical Research Council Centre of Research Excellence in Cognitive Health, is a Director of the National Health and Medical Research Council Dementia Care for Research Collaboration, and Co-Deputy Director of the Australian Research Council Centre of Excellence in Population Ageing Research. Kaarin conducts public health research into dementia risk reduction, ranging from analysis of cohort studies, development of risk assessment tools, and conducting risk reduction trials. A second focus is on older driver risk assessment and safety. Kaarin leads the PATH Through Life project, a large cohort study focusing on common mental disorders and cognitive function. She chairs the International Research Network on Dementia Prevention and is a member of the Governance Committee of the Global Council of Brain Health, an initiative supported by the American Association of Retired Persons. A very busy person and an incredibly successful person in Australia and internationally. So we're delighted to have Kaarin open the session today. We will ask Teresa in Hong Kong to go ahead with the pre-recorded video, and Kaarin will attend in the background and address questions at the end of the recorded presentation. So please go ahead, and good morning to Kaarin and everybody online.
Good morning, Professor Anstey. You can share your screen at any moment, please.
Okay. Okay, thank you for the introduction, and it's a pleasure to be speaking at this conference, and it's a very international conference, which is possibly one of the benefits of COVID that I think, particularly for us in Australia, it's made it much easier for us for these events because we don't have to travel so far. So I'm talking about will promoting brain health also prevent dementia? Quickly, just an outline. I'm going to discuss what we mean by brain health. I'll review the risk and protective factors, think about how modifiable they are. Then we'll look at combining risk factors, some multi-domain trials, and then sum up. So I just wanted to start by reminding everybody that the biggest risk factor for dementia is actually chronological age. And this is universal across the world in all regions. And we need to factor that in when we are thinking about risk reduction, particularly when a lot of our approaches actually enable people to live longer. So I also wanted to start off by discussing a sort of implicit theory that many of us work with who are working in dementia risk reduction and brain health. And often we don't actually make explicit the sort of theoretical models that are driving our work and the sort of assumptions that we have. But I would like to spend a little bit of time on this today and pull apart some of the assumptions that we're making. So what we start off with is thinking that if we reduce the risk factors for dementia and increase the protective factors, we will improve brain health. Then that will improve or maintain cognitive health, and that will reduce incident dementia. It's not necessarily that simple, though. There are some issues to consider to sort of clarify our thinking, and that need to be considered in the methodological interpretation of the research. Yes. The first is that we actually lack a definition of brain health. It's sort of surprising that many of us are working in the area, but we don't really have a common...
Professor Anstey?
Yes.
Technical support here has just told us that there is an issue with the audio is not being transmitted. They are here, so I just ask you to but Adam, okay, I mean no so it's okay. I'm really sorry because Murphy from the technical he's watching it from I really apologize. He
is
said
it working?
No audio. No, it is working. It's all fine because Adam is following it. I will just trim this part. I'm so sorry. And please, Professor William Wong, your microphone is on. I really apologize to interrupt.
Okay, no worries. So just getting back to what I was saying is that we actually lack a definition of brain health. There's also a need to have an explanation for cognitive reserve in our theories, because we do find that there isn't a one-on-one association between neuropathology and dementia, or risk factors and dementia. And the third point that we need to consider in the field is that premorbid intellectual function is protective, but it's often not included in our models. So I'm just going to explain each of these 3 points in more detail. The first one is the lack of a common definition of brain health. So there was a recent scoping review and concept analysis looking at this, and it's been published in the International Journal of Geriatric Psychiatry. And the authors of this found that, in fact, the term brain health is used in a variety of ways. And I just wanted to outline these and point out which I think is important for the work when we're thinking about brain health in relation to dementia risk reduction. So brain health has been thought of in terms of brain structure and function. There's also a disease model of brain health where we'd say a healthy brain is a brain that doesn't have any neuropathology, so it's defined by an absence of neuropathology. There's a cognitive model of brain health that thinks about the cognitive potential of a person. There's more of a preventive approach where we focus on modifiable risk factors. So sort of how do you take care of your brain? It's more like a public health messaging model. There's a holistic model of brain health, which relates to the WHO's new view of health, a functional capacity, and that integrates multiple dimensions of well-being. There's a multi-domain concept of brain health, which relates to several domains such as physical and mental and cognitive health. There's brain fitness. So some authors talk about brain fitness in relation to cognitive training and physical exercise, so physical fitness. There's a life course model of brain health that sees a proactive process where health is shaped by the environment and experience. Now, these are not mutually exclusive, and there's probably some benefit in all of these theories of brain health, but I do feel it would help us to have some more coherence and agreement about what we mean by the term brain health. I think obviously biological structure and function is essential to have a healthy brain. We need to understand the biology and the neuropathology. So the disease model has to be part of what we're talking about. We know that dementia is related to specific types of neuropathology. We also need to take a life course approach. So I've highlighted these 3 points in blue, and I think they're all components. I might add before I move on that in the broader field outside of dementia, I mean, people would be thinking of mental health as part of brain health or motor function. So, and these 2 points were raised by the authors. Now, the second point that's important for our implicit understanding of the relationship between brain health and risk of dementia is that a lot of people develop neuropathology but don't develop dementia. So, and I'm sure this has probably been pointed out in previous talks during the conference. I'm presenting a fairly old slide, but there's more recent studies that show exactly the same thing. And that is, if you take an autopsy, you'll find that a number of them do have significant neuropathology, but they did not develop dementia. So in this slide from the Cambridge MRC CFAS study, 70% of participants had vascular pathology at autopsy, and over 70% had tangles in their medial temporal lobe. So the issue here is that there's not a direct correlation between pathology and whether you're cognitive or brain reserve. There's this moderating factor. So when we're looking at brain health and risk of dementia, we also have this third factor, which is the cognitive reserve. And then there's another factor we need to consider, and that is our premorbid intellectual function. So, which is a study of civil servants from the UK, they estimated brain age, and brain age is a concept of where we look at, how fast your brain is aging. It's sort of statistically determined. You look at the average sort of health of the brain for an age, and then for each individual, is their brain more atrophy estimate. So people get a brain age which is positive or negative. The interesting thing about this study was that education and pre-morbid IQ were not associated with that brain age. And I think these are separate factors that need to be considered. So you've got your brain health and brain aging, you've got your cognitive reserve, and then you've also got the impact of pre-morbid intellectual function. And why is this so important? Well, I think in our research on dementia, we're looking at risk and protective factors for dementia. We often have studies of older people, say around 70. Many of the cohort studies start at age 70. And so if you look at those studies and you find an association between physical activity and, say, processing speed, it's often concluded that people who exercise more have faster processing speed. Now, the point is this is starting in late life, but it's possible that that association was also present in the 20s in the same cohort, because these associations, there's individual differences in cognitive function throughout the life course, and these are also associated with some of the lifestyle factors. So it's just a methodological point that we need to consider. So what are the common risk factors, and what are the common recommendations to reduce risk of dementia? I think you've already had a talk from Jill Livingston, and are probably well aware of the Lancet Commission that was published last year. So there are a number of lists of modifiable risk factors for dementia, and I'm just going to talk about a paper that summarised four of these lists of risk factors. That was the paper by Krivenak and colleagues, Promoting Successful Aging, that's in press in the Journal of Alzheimer's Disease, and they compare these 4 lists. There are also some other key systematic reviews that have done very, very detailed analyses of the entire body of evidence. There's Yu et al. In 2019, and my group also conducted an umbrella review of all of the published evidence on risk factors, and also published in 2019. So we now have a lot of data, or a lot of synthesis of what the risk factors for dementia and cognitive decline are. And there's not 100% agreement between the lists. And this is partly to do with different approaches different approaches in the different authoritative documents and the accumulation of evidence over time. So the more recent the document, the more risk factors are included, and we're tending to get more agreement over time. So the Lancet Commission lists physical activity, education, social engagement, hypertension, diabetes, high BMI in midlife, smoking in late life, depression, hearing loss, alcohol, heavy drinking in midlife, and head injury and air pollution as modifiable. And the Lancet Commission report was very important for identifying the stage of life at which these are important. So some are early life predictors, some are midlife, and some are late life. And it was based primarily on the observational evidence with some contribution from clinical trials. The WHO guidelines were published in 2019, and they took a different approach. The WHO guidelines are focused on the interventions that have been shown to reduce risk. So it's a different question than what are the risk factors. And that's why we're not seeing 100% agreement. And I think that point's very important for people to realise why we're getting slightly different lists here. So, so something could be identified as a risk factor in the literature, but we don't yet have evidence on whether risk reduction of that factor also improves cognitive decline. And that evidence may be lacking because the trials are not yet conducted, or it's impossible to conduct a trial. So something like air pollution, we can't conduct a randomized controlled trial on. So the WHO found physical activity, cognitive training, healthy diet, hypertension, diabetes management, cholesterol management, healthy weight, or management of overweight, and smoking interventions, and limiting alcohol, that there was evidence to recommend all of those interventions. Some of the interventions got a strong recommendation, and some got a weak recommendation, depending on the evidence. They didn't find sufficient evidence to recommend interventions for hearing loss or social engagement. One of the big differences in the list between the Lancet Commission and the WHO guidelines is diet. So the WHO made a strong recommendation for a healthy diet and a recommendation for the Mediterranean diet to reduce the risk of cognitive decline. The Lancet Commission didn't include diet in its main list of 12, but it does discuss diet in the actual report. And the reason it wasn't included in the 12 is that the literature is very complicated, and it didn't feel that there was a single clear message, but it's not that it wasn't discussed in the report. So just to make this point again, the evidence from the epidemiology on the risk factors focuses on long-term studies that are representative, where you've looked at a cohort over decades. So the advantages are that these are representative samples, they don't have exclusion and exclusion criteria, and they have a very long follow-up. Of course, they're subject to bias and selective attrition. The clinical trials that are used to evaluate the risk reduction interventions have a much stronger design because they're a randomized controlled trial. They have randomization to condition, but they have inclusion and exclusion criteria. So they're conducted on a highly selected sample, and the follow-ups tend to be short because we don't have funding to conduct a trial over decades, or we can't keep people in a trial for decades. So both of these approaches have big strengths and weaknesses, and we need to consider both sorts of evidence. There's also the animal models and experiments about the biological plausibility, which need to be considered when we interpret the evidence from both of these other two methodological approaches. So, for example, we might find midlife obesity is a risk factor for dementia in late life, which it is. It's been shown multiple times, but what is the actual mechanism for that? Is it a direct effect on the brain, or is it because midlife obesity increases some other factors such as increased risk of diabetes, blood glucose, etc.? So we need to understand the mechanism so that we can design the risk reduction interventions properly. So I've focused on, and most of those risk factors really focus on lifestyle and medical risk factors, because we're looking at what the individual themselves or their doctor can advise to reduce risk. But there are also the social determinants of health that are equally as important. And I think it's that we need to remember to include these when we talk about dementia risk reduction and brain health. So there has been evidence now for some time that early socioeconomic status and sort of social deprivation can impact brain development in children and academic school performance and cognitive development. So there was a systematic review that showed that almost every indicator of SES was associated with cognitive performance in children, and we would expect this would then have some impact on development of cognitive reserve. We've shown in our Australian Path Through Life project that participants that had reported financial hardship we could see they had a smaller hippocampal volume, and that's been shown in other studies that social disadvantage and these sort of life stressors can affect the brain. In our Path Through Life cohort, in some work led by research fellow Dr. Kim Kiley, we found that participants who report being unable to heat their home or going without basic needs or having severe hardship had poorer cognitive function and more cognitive decline over the follow-up period. In the US Health and Retirement Study, some analysis is done which looked at both early childhood socioeconomic status and adult socioeconomic position, with things like what type of high school, whether people completed college, and their income. And the basic message of that paper was that participants that had high SES, both in childhood and late life, had less cognitive decline. So their slope wasn't as steep in terms of their cognitive decline in old age over the period of this particular study, which was 10 years. The people that had the lower SES indicators at both occasions, so early in life and when the study was conducted, had faster cognitive decline. So there is a gradient there. So we need to consider these social determinants of health when we're looking at late life cognitive function and brain health. Again, we don't know the mechanism here, but it's a very important and consistent finding. Again, there's been other work from the English longitudinal study looking at wealth and cognitive risk of dementia. This study found that the effect was mainly in the lower tertile of the sample. So the risk between the high and low levels of wealth was partly explained by modifiable risk factors, but there was an effect here for the lowest wealth tertile having an increased risk of dementia. There didn't seem to be an effect for the medium, and no difference between medium and highest tertile. And another way of looking at the social determinants and how they can affect cognition is in the SHARE study. So this is a number of cohort studies across Europe that have similar and compatible measures, so we can actually ask these sorts of questions. And this study compared a number of these countries on the Regional Development Index, gender and cognition, and found that countries with a higher Regional Development Cognition Index, there was actually better performance of episodic memory. And the results, or the authors of this paper, also looked at gender differences and suggested that women benefit more from economic improvement than men. So the gender difference in memory performance was smaller in the countries that had a higher Regional Development Index. So you can see these very broad social factors are showing out, having an association. This is not causal, it's an association with cognition and gender in late life. So that's just finishing off on the social determinants. Now the next question I wanted to answer was, well, how important are these risk and protective factors that we're talking about so much? You know, are they accounting for 1%? Are they accounting for 20%? If we know the importance of these factors, it sort of guides our public health response and our investment in prevention funding from a government point of view. So to look at this, we can ask about the population attributable fraction and the cognitive disability-free life expectancy. They're two different methods of trying to quantify how much these risk factors are accounting for. The first one, I will talk to you about population attributable fraction. So in the Lancet Commission report, so the population attributable fraction is the amount, number of cases of dementia in the population that could be attributed to those risk factors. And it's calculated by combining the risk ratio with the prevalence. So if either of those numbers is high, that will determine. So you can have something that's has a high risk ratio, but it's very low prevalence. So it doesn't have as high a population attributable fraction. But when you have very common risk factors like insufficient physical activity and obesity that also have a high risk ratio, then you're going to get a big population attributable fraction. Altogether, the modifiable risk factors in the Lancet Commission were thought to account for about 40% of cases of dementia worldwide. Now, these are very broad brush numbers. There's lots of methodological assumptions being made, but this has been done in other countries on other data sets, and similarly large proportions have been found. We looked at the population attributable fraction in Australia. We found an even higher amount because we have very high rates of midlife obesity and insufficient physical activity in Australia. So that's just an example, and that was a shorter list of risk factors. So we found about 48% in the combined analysis. I would like to note that there is a big variation in these risk factors between countries. So remember, the population attributable fraction, it relates to the prevalence of the risk factor in the country as well as the risk ratio. So where the prevalence is lower, obviously that's going to account for fewer cases of dementia. And there are big differences between men and women and between countries. So we looked at Ghana, India, China, the US, and the Netherlands, and just plotted out, and this is publicly available data for common risk factors. And what you'll see is if you take something like obesity, that's much more common in the Netherlands and the United States, and not nearly as prevalent in Ghana, India, and China. And then there are some of these where there's a big difference between genders, and then there's others which you might find are higher. So no education is more prevalent in Ghana and India than in the US and the Netherlands. So, and even within countries, you're going to find big differences in the distribution of these risk factors and their prevalence. So again, it's one thing we can talk about the 40% of dementia accounted for by these risk factors, but you really, if you're looking at your country, and this is a very international conference, you would really need to know the local landscape of those risk factors and what the problem risk factors are that potentially account for a significant proportion of dementia, in order to determine what to do at the local level. The second way of quantifying the impact that modifiable risk factors have on on cognitive function in late life and dementia is to look at cognitive impairment-free life expectancy. So this is a different statistical approach. If you think about how long you're going to live, you have life expectancy, and that could be divided into time spent without cognitive impairment and time spent with cognitive impairment. So the time of your, this is a population average statistic, so the time that's spent without cognitive impairment is called cognitive impairment-free life expectancy. So we estimated this for Australia on a big data set where we pooled 9 longitudinal aging studies. And this has been done for many other countries as well. So the example here is Australia. And we looked at the cognitive impairment-free life expectancy for men and women, divided into low and high education. And then we looked at it according to whether they had 1, 2, 0, 1 or 2 risk factors. And the risk factors were smoking, obesity, and sedentary lifestyle. Now, to give you an idea of how much difference there can be based on these factors, if you take the high education, the women who were highly educated, who had no risk factors, at age 65, they had about 20 years of cognitive impairment-free life expectancy. On the other hand, if you take men of low education with the maximum number of risk factors, so 2 or more in this study, they only had about 12 years of cognitive impairment-free life expectancy. So there was an 8-year difference here, at least 8 years difference between these 2 groups. So these modifiable risk factors and social determinants of cognitive function in late life and brain health really are having a big impact that we can measure. They're not the small 1%, they're really quite major at the population level. Another way of looking at this cognitive health expectancy is this work we've done on the HRS study from the US, where we've looked at cardiovascular conditions and basically found a similar effect, that the number of cardiovascular conditions that a person has in middle age, say in their 50s, is related to the length of cognitive impairment-free life expectancy. And that was shown across all age groups, but evident again. So we know that cardiovascular conditions that are related to an increased risk of vascular dementia and Alzheimer's disease, and we can see it here in this type of estimate as well. So there's lots of assumptions that we make when we're looking at risk reduction and brain health. We're assuming that reversing the risk factor would reverse the risk. And that's not necessarily proven. That's why we need the randomized controlled trials. Often the statistics that we're reporting are quite aggregated, and they're not considering gender, but they're also not considering any of the other types of diversity. So we get a blanket statistic, 40% of this or 20%, but we're not considering specific population groups. And that's a need where we need to gather more data and develop those statistics. We assume the same findings apply across regions and ethnicities. We haven't considered migration. We make broad assumptions about thresholds. So again, this is all very aggregated, and our definition of high BMI, of sedentary, of a lot of these factors is quite blunt, and it may not be correct across cultures. So there may be a different optimal BMI in different countries or a different dietary pattern. So I'm just pointing out some of the issues we need to consider. We're also underestimating the competing risk of mortality. So I started off this talk saying chronological age is the biggest risk factor for dementia, which it is. Every time people get healthier and reduce these risk factors, they're getting older, they're going to live longer, and that increases age, which is a risk factor for dementia. So there's a little bit of circularity there. And we also need to think about the competing risk of mortality for other chronic diseases, that if somebody's a smoker, they're also at increased risk of dying from lung cancer, and we need to factor that into our models. And we also need to take a life course approach, of course. So it depends often where we took our data or a snapshot from, which part of the life course can actually influence the findings that we get. Having said all of that, the broad message stays the same. It's the nuance and the details and the application to the local area that's going to differ according to all of these factors. I've tried to pull all this together in a working model called the Cognitive Health Environment Life Course Model. And I'll just explain this model. It's just because we've got so much going on here, we need some working models to help us guide our research and thinking and public policy. So this model sort of says you have a lot of these sort of, in a sense, fixed effects. You've got your genetics, premorbid IQ, the education somebody has, sex and gender, geography, environment. These factors, a person in a sense is born into. I mean, some could arguably not be modifiable, but they're less modifiable. You then have the disease risk factors that people develop, which are more lifestyle, so insufficient physical activity, smoking, excess alcohol, social isolation, stress, poor diet, or environmental exposures. These increase your risk of chronic diseases such as diabetes, obesity, cardiovascular disease, kidney disease, stroke, and depression, so poor mental health. These diseases then really affect your vascular system, your brain. They are associated with increased neuroinflammation and neuropathology, white matter changes, the deposition of Alzheimer's pathology. And this accumulates over your life course to determine your brain health in old age, your cognitive function. But there is still this issue of reserve. So it's because we don't have this one-on-one correlation between the neuropathology and the state of the brain and our risk of dementia and our cognitive function. So all of this is moderated by something called brain and cognitive reserve, which we still don't fully understand, but it looks like it's related to things like your education and your intellectual stimulation throughout your life course, the amount that you've kept your brain active through occupational complexity and so forth. But it's still very much an area of study, trying to understand what reserve is. So, and the important thing here is that we have some of these factors compound on each other. So we might have smoking being a risk factor for heart disease, and heart disease being a smoking for dementia, and smoking being a risk factor for dementia. So we have a compounding of risk factors over the life course. I just wanted to really reiterate on that point, going back to the fact that a lot of the data that we're working with is from North America and Europe. So we still, again, need to bear in mind that we've got these models, we have some good evidence, but it is very much based on cohort data from North America and Europe. And in fact, my own region in Australia is underrepresented, Asia is underrepresented. A lot of, for example, data on BMI, we're lacking from, as a risk factor for dementia, of many Asian countries, we still don't have that data. So this can impact the field somewhat, particularly with things like diet. I think we really need to understand a lot more about dietary patterns from a range of countries. We may discover some real benefits of neuroprotective diets, in particular groups, regions, cultures, for example. So it is an issue we need to just remember. So where this would come in is that those risk ratios that are used in those statistical models end up being derived from the cohort studies, and those cohort studies were taken from specific regions. So it might be that those risk ratios differ in different regions or in different countries. I also think we need to consider the amount of evidence and the robustness. So we've got all these risk factors and the evidence is accumulating, but we have more evidence in some areas. So we actually have, my group did a systematic review to look at the quantity and the quality of the evidence we have on risk factors for dementia. And what we found was that the most evidence is actually for diet, that we found 90 studies contributing to the meta-analyses on diet. The reason it's just complicated because diet is broken down into both dietary pattern and nutrients. There's also a lot of studies on smoking. It's a very robust finding from many, many studies. There's lots of studies on physical activity, a lot on alcohol. There's a lot less on cognitive engagement. So if you look at the cohort studies, the data is much weaker on whether keeping cognitively active is protective than, say, the data on physical activity. And then there was very limited data on stress from cohort studies, because cohort studies don't tend to measure stress. They measure things like depression and anxiety and life events, but we don't often see stress scales in those studies. So there's a big range in the amount of data. The studies also vary according to whether they measured exposure in midlife or late life. And that's also important because we don't know if, for example, all of the data on smoking is from studies of older adults. We don't know how smoking in middle age impacts brain health in late life. We can infer, but we don't have as much direct evidence on that. And same for some of the other protective factors. And sometimes it's quite surprising because there's things that we all assume, we all know. And then when you dig deeper, you think, well, actually, there's nothing on midlife for that risk factor. So I think it's just important to remember that. I'm just going to discuss a few of the key risk factors now that are modifiable that I think everybody is interested in and can relate to. So I thought I'd just present a bit of data on things like diet and physical activity. So diet, as you saw, there's the most evidence on diet. There was a meta-analysis in 2014 showing that the Medi-style diet was associated with a 33% reduced risk of MCI or Alzheimer's disease over 2 to 8 years. There's been other systematic reviews that have found a protective effect of diet and also the dietary approaches to stop hypertension. And there's been studies of interventions, dietary interventions that have shown to have a benefit. The diet for which there appears to be the most evidence now is the MIND diet, which is a form of the Mediterranean diet, but it emphasises the neuroprotective foods within the Mediterranean and DASH diets. It was developed by Martha Morris in 2015. I put in the slide on the left is the taken from the journal article where she described the pattern, but she says that it's an evolving diet. As we get more evidence, this will be refined. In cohort studies, it's been shown to this dietary pattern. So we score up people's food frequency questionnaires to develop a score of, say, the Medi, how well somebody adheres to Medi or MIND diet or another diet. And then they do long-term cohort studies. And what's been found is people that adhere to this dietary pattern have a reduced risk of Alzheimer's pathology at autopsy, as well as a reduced risk of cognitive decline and dementia. So initially, this had only been found in the United States. And our group in Australia wanted to look at the MIND diet in an Australian cohort. So we scored up our cohort's food frequency questionnaire from the Path Through Life study. We had 1,220 Australians aged 60 to 64. We scored up their questionnaire and followed them for 12 years, and we found people who adhered to the MIND dietary pattern had a reduced risk of cognitive impairment and dementia as well. And this was the first time the MIND diet had been shown to be effective outside the US. So we're really pleased with that, and it's really an active area of research looking at the dietary patterns and nutrients, and I think it's going to continue to be a very interesting and emerging area, especially if we can get some findings from other countries. In our Path Through Life study, we also looked at diet and brain. So in this particular paper, the focus was on the hippocampus, and the participants were divided into those with poor, average or good dietary quality based on the same food frequency questionnaire. So a diet high in meat, potatoes and soft drinks was considered poorer, and also low in fruit and vegetables. And what we found was that people with a better, healthier dietary pattern had a bigger hippocampal volume, but that's not causal. Obviously, it's a cross-sectional finding. But then longitudinally, this was over 2 waves. People with a better high-quality diet had less hippocampal atrophy over 4 years. So that was some more converging evidence on the benefits of a healthy diet for brain aging and brain health. And I'd like to move on to physical activity. Physical activity is probably the modifiable risk factor with the most evidence as being beneficial for brain health and reducing a risk of dementia. One of the questions that I usually get when I give talks like this to the public is, well, how much, what sort, am I doing the right sort of physical activity? We want more specific information. So I usually refer to this systematic review, which was very useful because it looked at the studies that had divided the participants into those who adhered to their national guidelines for physical activity versus those who didn't meet those guidelines. So the national guidelines in most countries are for 150 minutes of moderate to vigorous physical activity a week, or a brisk walk for 20 to 30 minutes most days. So that's fairly common across the world. I mean, there's some variation, but that's the typical recommendation. Now, in these systematic reviews, the overall conclusion of the authors after pulling the evidence was that people who stuck to those guidelines during the last 5 years had a 40% reduced risk of Alzheimer's disease. So that's a very concrete finding that you could tell your patients or your friends, stick to your national guidelines and you will get a cognitive benefit. Now, there's a lot more research that's gone into much more detail on the benefits of doing a lot more and intensity of exercise. So I'll outline some of that. We looked in our umbrella review, we found 6 systematic reviews of physical activity in Alzheimer's disease, and all of them had a reduced risk and an effect across several cognitive domains. And the WHO guidelines looked at exercise interventions, and they also found and make a strong recommendation about physical activity. And this systematic review looked at the types of physical activity that were protective against cognitive decline. So this wasn't on dementia, it was on cognitive decline, and they looked at randomized controlled trials conducted on community dwelling adults aged 50 and older. They had aerobic, 18 on aerobic physical activity, 13 on resistance training, 10 on multi-component training, 4 on Tai Chi and 2 on yoga. And they found that exercise was beneficial for executive function, memory and working memory, but they didn't find a benefit for global cognition. And all sorts of physical activity were beneficial except for yoga. And they recommended about 45 to 60 minutes a week, but not a very short duration and not very long durations. But I think the key finding from this systematic review really was about intensity. They found that moderate and high intensity, but not low intensity, were beneficial. And this is consistent with national guidelines, which says you should exercise at moderate to vigorous levels to get the benefit. But it differs from some of the other evidence for exercise in aging. So generally, amongst older people, we would say any physical activity is better than none, and it all can have a benefit. So even walking for 5 minutes, if you're previously sedentary, is beneficial. So as a general message, all physical activity is beneficial, but to get that impact on brain health, it seems to have to be moderate to vigorous intensity. So we've looked at these risk factors all as individual risk factors. The evidence is often presented as a list of individual risk factors, but increasingly researchers are looking at lifestyle and the way risk factors work together and what a pattern of healthy lifestyle versus unhealthy lifestyle looks like. In this study, the authors looked at Life Simple Sevens from the 3-city study in France and found that people who had adhered to all of Life Simple Sevens had less cognitive decline than people who had lower adherence. And they included not smoking, having a BMI of less than 25, regular physical activity, eating fish 2 or more times a week, vegetables, fruit and vegetables 3 or more times a day, regular fasting glucose of less than 100 and blood pressure of less than 120, and both of those being untreated. So now I'm going to quickly talk about multi-domain interventions. The evidence on these is much more recent, and really the most influential multi-domain intervention is the FINGER trial, which had its first findings published in 2015. There's been 3 completed large multi-domain trials, the FINGER, MAPT and PRE-DIVA. They were all focused on older adults, so quite old, with 2 of them including participants with average or slightly declined cognition. So that was FINGER and MAPT. And the FINGER trial had a positive finding. So the people that received a very intensive multi-domain intervention had less cognitive decline. So they actually improved more on executive function, their neuropsychological test battery and processing speed. The other 2 trials didn't get a benefit, and there was a number of reasons for that. So the PRE-DIVA trial was looking for dementia outcomes, which are in a sense much harder to see than cognitive outcomes. That was conducted in a primary care setting. They have looked at some findings for in their subgroup analysis. I just wanted to tell you today about some smaller trials. So in addition to these really large trials, there have been a number of groups around the world conducting small online risk reduction trials, and we have conducted a few in Australia. So I've led a series of the Body, Brain, Life trials. So I'll just tell you about 2 of these. The first one was conducted on volunteers from the community aged about 55. They had to have more than 2 dementia risk factors and less than 2 protective factors to be included in our study. And they were participating in an online intervention that was used behaviour change principles. And they had 2 education modules where we taught them about brain health and risk reduction. And then they completed 5 online behaviour change modules looking at diet, physical activity, social engagement, etc. And the outcome measure was a risk score for dementia. It wasn't cognition. And we found that on the risk score, they had a benefit over 6 months. So that was promising. The reason we don't use cognition in middle-aged adults, remember they were in their 50s, is that we don't see cognitive decline in middle age. In fact, we often see cognitive improvement. So in our cohort study, Path Through Life, on average, the red line is the average cognitive change over 8 years. In our midlife cohort, it's actually 0. It's not statistically significant. So in a midlife trial on dementia risk reduction, we can't use cognition as the primary outcome. We have to use a proxy or a surrogate outcome. And so we use a score, a risk reduction, a risk scale. And we've developed the ANU-ADRI. You can find it on our website. And we validated on the Kung-Salmon project, the US cardiovascular study, and the MAP, memory and aging study in the US. And it does predict incident dementia and Alzheimer's disease in those cohorts. And we validated on other studies since then. We then wanted to look at body-brain life in a much more at-risk sample. So the first study was like just developing the methodology. This time we looked at adults from primary care. We had 125, and we had a control group that the first time we had an email control group. The second time we have a similar email control group, but we also had the lifestyle management program from the practice. It was a similar intervention. We actually added a couple more modules on mental health. We rewrote the modules to make them more user-friendly because we got feedback from consumers. The average age of this sample was 50. And the average BMI was 34, so we had an obese sample, and we had a large number of people with type 2 diabetes and high glucose. So it was a group that we would consider at risk of late life dementia in primary care. They completed our modules. They also, in addition to the online intervention, we had a face-to-face session with an exercise physiologist and a face-to-face session with a dietitian, who gave them personalised advice on physical activity and diet and followed up on the phone with them. And what we found was that the intervention did work. They did reduce their risks, their score on the ANU-ADRI, and the benefit was actually maintained at 62 weeks. So we felt, at which time the funding had stopped and we stopped following them up, but this was more evidence in support of this approach. So there have been a lot of smaller trials. With the smaller trials, we've been able to update our methodology as we go and get consumer feedback. We've employed co-design, particularly in primary care. I'm just going to mention a couple of things with the trials. They do require a lot of participation and commitment from participants. So that's can be a negative in terms of trying to get people to participate who may not be motivated or health is about their health. The online trials, they have been analysed as enough for this very small meta-analysis, but they have shown a benefit. They also have shown benefit for reducing overall morbidity of chronic disease and improving activities of daily living. And we've also done a cost benefits analysis and found that even if we projected quite a lot of decay in the intervention over time, given the cost of dementia in Australia, they are quite cost effective, and that didn't take into account the benefits for other types of chronic disease. One last caveat is that the trials are very short, and we know the exposure to the risk factors is very long, so we need to consider that. So just to summarise, there's a the relationship is very complex. We need to think about premorbid intellectual function. We need to think about social determinants of health to distinguish between risk factors and risk reduction interventions. But there does seem to be an additive effect of the risk factors and then a benefit of the multi-domain risk reduction interventions. And risk reduction for promoting brain health is cost effective and has many benefits for healthy ageing. So thank you. And I'd just like to acknowledge my team and my funding. I'm happy to answer questions.
Thank you so much, Kaarin. A wonderful presentation, extremely comprehensive, I must say. And what's brilliant is that you've touched on many of the issues that we have addressed to date in the conference. I'd like to raise a couple with you. One is diet. So we had a conversation with Professor Kappa in Northern Italy, in Milano, about diet. He was very clear that the problem with the dietary research is the implications for translation to the community. So he made a really great point, I think, which is very relevant, in that the Mediterranean diet is not that common in Milano. So even though it's assumed that all of Italian diet is it's really not true. So the challenge is going to a community sample in northern Italy and trying to impose changes to diet that are fixed on what's perceived to be a Mediterranean diet. So I wonder if you could comment a bit on that, because I appreciate fully the value of the work on diet, and I know you yourself really have found this to be a very critical issue. And I would like to ask a more specific question, which is about the contribution potentially of specific dietary factors in, let's say, rural dwelling Indigenous Australian communities. Maybe you could speak on that topic briefly.
Right. Okay, thank you. So that's a number of points. I think, yeah, they're two different angles. So one is the evidence, and then one is the how do we translate it into communities. So there's two things there. One is that with things like the Mediterranean diet and the MIND diet, it's the dietary pattern rather than the diet per se. So it's things like the quantity. So with the MIND diet, it's eating green leafy vegetables every day. That was unique. So it's not just, a lot of the healthy diets recommend 5 vegetables a day, but they don't stipulate that you have leafy green vegetables every day. The MIND diet stipulates that those leafy green vegetables could be different in different countries. So what you eat could be spinach in one country, or it could be Vietnamese vegetables in another country. So I think that's part of it. It's us understanding with more research, it's these groups of foods. Whereas in the actual example of that food may differ in different parts of Italy or in different parts of Asia. So that's one thing. So we're looking at dietary pattern and understanding, and once we understand the nutrients that are neuroprotective, those nutrients may be in some foods we're not even including, or in different ethnic diets that we don't, different berries or whatever. So part of it's being open to the fact that we need to keep looking for what the underlying neuroprotective element is in the food, and whether those elements are then in other foods in other dietary patterns that are not yet included. The question about Indigenous diets in Australia, there's a lot of bush foods, a lot of natural foods in Australia, which I don't know. Again, it's really the same point. I am sure they would have a lot of benefits, but we don't know. We haven't got sort of cohort studies that have linked them to risk of dementia. So I think there's sort of, in a sense, calling it the Mediterranean diet has been good and bad in the same way, because it's made it sound like if you don't like Mediterranean food, well, then you can't go on the Mediterranean diet. And it isn't that. It's about the pattern. It's about the good oil, the healthy oil, eating fish regularly, having lots of green vegetables, which could apply to a number of diets that are not Mediterranean. So that's where I guess the language is also important here. And because it involves culture, and people have developed their diet based on their local food culture, it's something it is very it's quite difficult to change, and we need to be much more culturally sensitive, I think, in the way we study and communicate around diet.
Thank you. Just a quick comment to bring it to the Greater Bay Area. Sugars are very rarely used in Chinese diets, but that's changing. So if we look across, as you pointed out, the different geographical regions of the Greater Bay Area, sugar consumption is rising. Bubble tea, for example.
Right, yeah.
Amongst the young, whereas in the older population, it's vanishingly rare to see sugar ever used in seniors throughout mainland China. But I think that's a topic for another time. We've got a couple of interesting questions here that I would like to read out. I've curated them because I think they're quite unique in the context of what we heard so far. The first question is, do interventions to reduce risk factors for dementia, such as SES differ across the lifespan?
That's a great question. I would imagine yes. So, I mean, an intervention to reduce disparity or low socioeconomic status, I think it's going to differ. I mean, in children, the biggest issues are nutrition and early education and access to healthcare. I mean, some of them are going to be generic, so access to good healthcare across the life course. But yeah, I mean, we don't have any evidence on that. It's such a good question. It's something we need to look at. Yeah. But I think all of these things are different at different stages of a life course, because they're going to interact with your family stage, your person, whether it's a woman with or man with children, occupational situations. So yes, they're going to have to be tailored for the life course.
Thank you. Thank you. I agree. It was a really interesting and thoughtful.
Yeah.
And the second question that's also related, could you comment on possible gender differences in terms of adherence to interventions targeting modifiable factors?
That's another good question. I think we tend to find that women, well, at least in Australia, that women are more likely to participate in these sort of healthy lifestyle programs. They're more health conscious and they see their GP more often. So there are definitely gender differences in Australia. But again, I think it might be something we have to look at on a country by country level, because I think in some countries health usage is higher among men. So it might depend on accessibility to health care for women and versus men in different countries as well.
Yeah, and I really feel these cultural differences in a way that are not so obvious, but certainly we would highlight those in terms of the comparative work that you mentioned so clearly, and the regional differences as well that correlate with those cultural those cultural effects. So if I could just return to Australia and Indigenous communities, the cultural differences there are very sharp. And I guess there is a requirement for us to try to look more closely instead of assuming a homogeneous sample. And you've made that point extremely well, and I thank you so much. I would also like to just mention that all talks that are recorded will be available to participants, so anyone can go back and see all of the talks so far presented in the conference, and I would encourage people to do so. They will be uploaded with permission, and Kaarin has agreed to let us do that, which is fantastic. This is a masterclass in itself, in fact, in epidemiology, specifically in dementia. I didn't mention that Kaarin is indeed a psychologist, as am I, and so the training in psychology in Australia has given a really wonderful foundation to launch into a new discipline, which I would say is critical in terms of the modifiable factors. So behavioral science can help a great deal. Would you agree in your experience?
Yes, absolutely. I think the combination of behavioral science with epidemiology is essential, really, in addressing these problems.
Well, thank you again. Unfortunately, due to time constraints, we will have to pass on, but thank you so much for your fantastic presentation. And we wish you well in the future. You're very successful in grant getting, and we wish you well in future resource allocation, so thank you again, Kaarin, and we'll move on.
Brendan.
Okay.
Thank you, Maria. Bye-bye.
Bye-bye.